These are the MedEd Grand Rounds. These are the Curricular Affairs updates. For anyone that doesn't know me, my name's Priya Sikka. I'm part of the Curricular Affairs team working in medical education. So I'm going to be kicking off the Curricular Affairs updates that myself, Dr. Soriano, and Dr. Karani put together from AAMC. So the objectives of this session, I'll be going over changes that have been made to Step 2 CS and Step 3 exams. I'll also review some new and changed LCME accreditation standards, and then I'll pass it over to Dr. Soriano to talk about the AAMC curriculum inventory, MedEd portal, publications, iCollaborative, and CE directory, and give us some sense of how medical students are using social media. So I'll start with the NBME updates on the board examinations, starting with Step 2 CS. Just a little background, because I wasn't sure how much the entire audience would know about Step 2 CS. So this is the clinical skills exam that's taken by students in their 4th year. It is a graduation requirement for Mount Sinai. It's a very practical exam that's meant to assess students' fundamental clinical skills and just make sure that under supervision they're able to provide safe and effective patient care. NBME has been working over the past year or so to focus this exam a bit more to make sure that we are more able to assess students' communication and interpersonal skills and their clinical reasoning abilities. So the first change that they've made to this exam is some changes to the communication and interpersonal skills checklist. So this is a checklist that is used by the evaluators to make sure students have the full range of competencies under communication skills. So the approach that they took was they divided the communication skills into some functions that they thought were really important to kind of describe in a bit more depth. So in June, they divided the communication and interpersonal skills section into these 5 functions. And then under each of these 5 functions, they've listed some sub-functions or actual behaviors that the evaluators are meant to look at when the examinees are performing with their SP, or standardized patient. So for example, the first function you see here is fostering the relationship. So what the examinee would look for is, in terms of behaviors, is does the examinee express an interest in the patient as a person? Have they treated the patient with respect? Do they listen and pay attention to the patient? Under the gathering information function, the behaviors that the evaluators are looking for are, did the examinee encourage the patient to tell their story? Did they explore the patient's reaction to their illness or to the problem? Under the providing information function, the evaluator will be looking to see whether the examinee provided information related to their working diagnosis. Did they provide the patient with some information about the next steps that will be taken? And then under the making decisions section, there's a basic section that's in place right now, and then there'll be an advanced section coming up that hasn't been described fully yet. But under the basic making decisions section, the evaluators are checking to see whether the examinee elicited the patient's perspective on the diagnosis and the next steps that they'll be taking, and did they finalize plans for the next steps. And then in the 5th section, supporting emotions basic, which is established, and then again there's an advanced section that hasn't been determined just yet. But under basic supporting emotions, the evaluator's checking to see whether the examinee facilitated the patient's expression of an implied or a stated emotion or something that's important to them. So this list of functions and all of the behaviors that I just described, they're available on the NBME website, and there's a hyperlink to this here. I don't know if the presentations are made available to the audience members after. But if you'd like to email me, I can send you the slides, certainly. So several, as I've listed here, these are the functions that are still being developed, and they're hoping to be rolled out in 2013. So we have communicated these changes to the students because it's really important for them to take into account, obviously, when they're interacting with the patients, that they need to be really attentive to these functions when they're interacting with the SPs, and they really need to focus their history taking and their physical exam on making sure that they elicit this kind of information. And if they ask unfocused history questions or if they do an unfocused physical exam, they risk taking more time in the exam and getting a lower score. The second big change that's been made to Step 2 CS is there's been the addition of a patient note. Since June, this patient note has been introduced, and the students do need to complete the entire patient note, or again, they risk getting a lower score. So they have their encounter with their SP, and they're meant to document all of their history and physical exam findings, and they're meant to also list any diagnostic studies that they would like ordered after their visits. And then the examinee has to write down a maximum of 3 differential diagnoses, and they do have to write down 3 and list them in order of likelihood, and then they have to support that or refute that with any history or physical exam findings that they had. So on the NBME website, there's actually sample patient notes that the students can look at, and there's also a simulation of the program that the students will be writing the patient note in, so they can kind of familiarize themselves with that software. We've shared all this information about the step 2, the patient note, and the different functions with the clerkship directors so that they can field any student questions related to those changes. And also important to note is all of the clerkship directors are involved in Compass 2, which is the exam that we use at Sinai to prepare students for Step 2 CS. So it's important, obviously, that the people that are involved in developing the Compass 2 scenarios know what Step 2 tests the students on, so they can adjust the different scenarios accordingly and make sure we're giving them the best preparation possible. Okay, so on to Step 3. So again, background on what Step 3 is for people that don't know. This is the exam that students usually take after they've graduated from medical school. Different GME programs have different expectations of when students take Step 3. And this exam is really more geared towards making sure the examinee can apply their medical knowledge and their understanding of biomedical and clinical science for the unsupervised practice of medicine, with an emphasis on patient management in the ambulatory setting. Some changes that are anticipated in 2013 to Step 3. Basically, starting from the bottom bullet point, actually, you'll be able to see that there'll be more questions now related to research, abstracts, and pharmaceutical advertisement questions, which are really designed to make sure that examinees are able to interpret information that's presented in that format. Over the next few years, there will be a gradual increase in the number of test items that assess the examinee's knowledge of foundational science. Is there any questions about the NBME updates before I move on to LCME? No? Okay, so Dr. Karani provided me with these LCME updates that, and she apologizes for not being able to be here to present them herself, but she assured me that if you have questions, more detailed questions about these, you can contact her. Just when you thought we were done with LCME, the session at AAMC this year, as every year, really focused on what you can do to maintain your LCME readiness. So what can we do? We've had a successful accreditation cycle now. What can we do to make sure that we're maintaining our accreditation with our standards, and when LCME comes here next, we're not struggling to find information. So the basic rules are to stay up to date on what new standards are. So this is what the AAMC conference updates you on. To also monitor changes to any of the current standards and their annotations, and just to make sure that anything that we've been in compliance with, we're actually sustaining and monitoring any efforts that we've had to make sure we're maintaining that compliance. So this presentation is going to highlight one new standard that LCME has put out, one changed standard, and one proposed new standard. So the new standard that we're going to highlight is ED 25A, which pertains to the supervision of medical student learning, and that it must be provided throughout the clerkship by the member institution's faculty. So this is the new standard. Just going to read it out so that we're all clear. I'm just going to read out the highlighted section. So the accountability of physicians and non-physicians who supervise medical students in clinical learning settings will be clearly described in the program's policies and procedures. The level of responsibility delegated to the student by the supervisor will be appropriate for the student's level of training, and the activities supervised will be within the scope of practice of the supervising health professional. So what are we doing to make sure that we are staying in compliance with this new standard? So we have delineated the level of responsibilities for students for each year. So for each clerkship, we have a list of must-see diagnoses, and the students have to document what role they played in performing that diagnosis. That they log that into eValue, which is our system that we use to track students' compliance with what diagnoses they've seen and what procedures they've completed. We've developed a clear supervision policy for all faculty and house staff to make sure that any activities that the students conduct are supervised and they're within the scope of the practice of the supervising health professional. And we have also included a policy in our student handbook and in faculty handbooks. So the next standard I'm going to talk about is MS-20. So that is a standard that has changed. This is pertaining to electives that medical students participate in. So if a medical student at a medical education program is permitted to take an elective under the auspices of another medical education program, there should be a centralized system in the dean's office at the home program to review the proposed extramural elective to make sure that we are assured that there's not going to be any issues, that we are aware of any issues with that particular site. So this highlighted in red, the bulleted list here tells you what kind of issues we're looking at to make sure that we're not approving an elective without being informed of potential risks to the health and safety of patients, students, and the community, the availability of emergency care, possibility of natural disasters, exposure to disease, et cetera, et cetera. So how are we making sure that we stay on top of these issues? So right now, the AAMC has a website called VSAS, which is the Visiting Student Application Service. So that is the website through which our students apply for electives at other institutions. So we're really having discussions back and forth with AAMC to find out what they are doing to make sure that we are aware of any issues at institutions that participate through VSAS. So we're kind of expecting that VSAS is going to be collecting this information about their different sites and posting it here. We're also developing questions on our elective development form, so our new elective proposal form. Anytime an institution or a department approaches us and says they want to create a new elective opportunity, we're including some questions there to make sure that we are eliciting that kind of information before we approve a new elective. And we're also modifying our elective approval office process to make sure that we're building in enough time for the director of student electives, the curricular affairs team to kind of vet these sites prior to the start date of the elective. So finally, we've got ED 19A, which is a proposed new standard, which states the core curriculum of a medical education program must prepare students to function collaboratively on healthcare teams that include other health professionals. So this is really going back to the theme of interprofessionalism. This has not been approved yet. It is pending public comment and then final vote in 2013. So that's it for the LCME updates. Are there any questions before I pass it to Dr. Soriano? Yes.
That new policy 25A,
Mm-hmm.
you said you update the student and faculty handbooks. Is this something that should be in the House Dev manual too?
Yes, I think it should.
Paul Johnson.
Paul Johnson?
6694.
Okay, we'll make sure he gets a copy.
Like delegating there.
America's a great country, Dr. Mark.
Great. All right, thanks.
Thanks, Priya. Just want to note that Priya is actually on vacation for the next 2 weeks, and she just came in today just to give this grand round. So just want to applaud her for coming. So in line with the objective that each medical school is actually LCME ready, the AAMC is actually providing a suite of services to provide each medical school with the tools necessary to make sure they are all LCME compliant, as well as have ready access to data that the LCME requires. So just want to highlight 3 of the services that will be launched in January 2012, and one of them will be launched in the summer of 2012. The first is the Curriculum Inventory and Reports, or CIR. For those of you who are familiar with Kermit, which is the bane of our existence, it's dead. So what's being replaced, what Kermit's being replaced with is the Curriculum Inventory and Reports. So this is designed to be a repository as well as a reporting tool for member medical schools for benchmarking as well as for research purposes. The beauty of the Curriculum Inventory Report is that there's no manual typing in of the curriculum into the database, which Kermit had problems with. So it relies on either sponsored learning management systems or special learning management systems where it can communicate directly with the system. Fortunately, we're in the process of purchasing Knowledge Map, which is one of the learning management systems wherein our curriculum can directly communicate with CIR. So this will be launched sometime in January 2012. Some of the reports are already up on the WMC website, so you can actually compare the medical schools within the United States and Canada. The second service is called ASSET, or the Accreditation Standard Self-Evaluation Tool. So this service is designed as a pre-populated database that the LCME as well as the WMC receives from its member medical schools every year. So this is used to provide medical schools with a reporting tool wherein it lessens the paperwork or paper documentations that's required if they're undergoing LCM review. The third service is called the Asset Dashboard. This is an online tool wherein a medical school can compare itself with other institutions within the country and in Canada regarding its missions, research, clinical services, as well as education. So you don't have to wait every 8 years to document and compare your curriculum, your education, your research, as well as your clinical services with other medical schools, but you can do it on an annual basis, on every 2 years, every 4 years, if you need be, in terms of mini reviews to make sure that you're LCME ready when that site visit comes. So those are the suites of services that I just want to make sure that everybody is aware of. One interesting session in WMC was a national survey that was done by the WMC as well as people from Penn. This is a national survey of a nested sample of medical students in the United States and how they use social media. As we all know, they use social media often. The results show that 92% currently have some activity in Facebook, and over half of them connect with Facebook several times a day. And 73% have had this account for more than 5 years. And when asked if what's the most useful thing for them in gathering and sharing information between regarding medical training interests, the majority still prefer the email system. I know some of us, especially the institution, experimenting on putting things on a blog or having Facebook interface with potential candidates as well as medical students. Less than half of them prefer this route of delivering information. Texting and syndication feeds and Twitter is definitely all the way down. So if you're considering experimenting, reaching out to potential medical students or to current medical students, Twitter probably is not the way to go. Another question that they answered was the useful tool of communicating with medical personnel, and still overwhelmingly email is still the best way to reach their medical school course directors, faculty, and personnel. Texting, Facebook, blogs, and Twitter, I know that several course directors and curriculum directors have experimented on this. It's not still the best way to communicate with the medical students. One interesting thing that I found in the results was this first bullet, which is that almost 73% of them use the same profile for personal and medical professional life. They don't see a difference. The majority of them don't see a difference between their email account, that is mssm.edu, and their Gmail account, which is more of their personal account. All the pushback that we've received from medical students of forcing them to our MSSM.edu account and using them as a separate medical school account aside from their Gmail account, this is the reason why there's a lot of pushback regarding that. They don't see a difference between an email or Facebook account that's for personal use and for medical professional use. 45% of them never and only 3% frequently share health-related information with Facebook network. So I think that's also one thing we need to think about regarding the activity of our medical students using social media. Questions? So a few updates on Meded Portal. As you may know, for those of you who may be familiar with Meded Portal, is the main venue wherein we can collaborate as well as promote educational scholarship through the internet and throughout the world. Erica, I know, is an associate editor for chronic illness, and I'm an associate editor for geriatrics for Meded Portal. This is really the best venue to share educational teaching as well as assessment resources. Since its inception, the Meded Portal is designed as a scholarly journal in the same way that print journals were designed. A third of submissions to Meded Portal are actually now rejected. Only 19% are accepted through its strict peer review process, and almost half of them, when first submitted, need some revisions that need to be achieved. But the majority of those that require revisions still end up being accepted. Okay. The biggest myth regarding submission to Meded Portal is the fact that you need to be multimedia. That the more multimedia you are, the more simulation you have in your product, is the more likely it will get accepted. That's not true. Even a simple PowerPoint presentation on a knowledge gap within medical education has a very high likelihood of being accepted. So I just want to highlight that because that's the first myth that a lot of potential authors usually ask us. This was a study by Chris Candler, who's the editor-in-chief of Meded Portal, and asked whether Meded Portal publications count towards promotion tenure. And he surveyed the first authors of Meded Portal submissions and publications. And it appears that most scholarly products such as Meded Portal publications appear to be accepted, but some, but not all institutions. And he only asked that for medical schools, that medical schools still do not have a consistent policy regarding non-traditional scholarly work. Fortunately, here at Mount Sinai, our A&P are familiar with Meded Portal and view it as a way towards promotion. My last slide focuses on the expanding role of Meded Portal in terms of delivering services to the medical education community. The traditional Meded Portal, which is now called Publications, this is the peer-reviewed portal to submit as well as to look for medical education materials as well as dental education materials for teaching as well as for assessment. So now it's called Meded Portal Publications. There's a new suite called iCollaborative. So this is a portal for non-peer-reviewed materials. So this is looked at as a sandbox, wherein if you'd like to collaborate with other potential educators throughout the world, you can post them on this iCollaborative portal and work through that process. So you can submit new approaches, new practices, and new strategies for medical education, both teaching, instruction, as well as for assessment. So the last suite is the CE directory, or continuing education directory. So this is an online database wherein member schools can submit their continuing education courses, and this is a way for potential participants can look for high quality continuing education courses of its member institutions. That's it. Questions? Great. So I'm just going to pass over to Gary Butts with an update on culture.
Thank you, Rainier. realize we had such an attendance here today. Good afternoon, I'm Gary Butts. I think you all know what I do. I'm going to take a slightly different spin on updates. How many of you were actually at the AAMC? Small group. And how many of you attended any of the diversity sessions, the GDI-sponsored sessions? Okay. So that will help me in how much detail I share with you. And feel free to ask questions along the way, and I will pause in between. So what I'm going to do, and get this going right, is speak about a few things. One, just a reminder of what the new group on diversity, now 4 years old, the group on diversity and inclusion is and what its priorities are, and then 4 sessions in brief by way of update. And then the session I want to spend a little bit more time on is something that will have particular impact on pretty much all of what we do. That's the way I would frame it, and especially as it relates to sustaining and or increasing the diversity of our student body, and then subsequently the pipelines towards faculty. My reason for focusing on these sessions is several-fold, but particularly becoming more and more of the mind that the more you all are informed, in addition to what we know and have developed a fair amount of expertise in CMCA, spreading that information to the masses, you all, I think, just makes us that much more powerful and effective as we move along. Clearly, there are challenges with that. Managing the information, despite the fact that it's in front of you, will forever be a challenge, particularly with the core responsibilities for diversity still resting with myself as Associate Dean for Diversity and the CMCA. As a reminder, this is the mission and focus areas for the GDI. Still, largely the focus is on faculty, GME, and to some degree they help to connect some of the dots with the group on student affairs through a committee on diversity affairs as it relates to medical student diversity. The membership of GDI comes in from several directions. Institutional members, I am Mount Sinai's institutional rep, and non-institutional reps. Any of you, just based on your interest, can become a member of the group on diversity and inclusion. Right? So I encourage those of you who might be leaning in that direction to just send an email, connect, and any and all of the information that becomes available through GI will come directly to you. These are definitions, again, just as a reminder. Diversity defined quite broadly these days. However, the core priority still is, a target still is that of groups underrepresented in medicine as defined by population data. The definition for inclusion and the relationship between inclusion and supporting diversity and health equity as defined by the CDC. So these are slides, by the way. I think all of you must know that most of the sessions that were presented at the AAMC have been cataloged and available on the AAMC website. Go to the site, look at the fall meeting. You can pull this up just as well as I can. Yes?
Is it okay to ask questions? Or?
Yeah.
Can you describe at all the process that the GDI went through to decide that the focus was going to be GME and faculty and not include medical students in that?
So it was, yes, I can. And in fact, I was part of that process, and so I was on the initial steering committee that supported that very painful, as you can imagine, evolution. You may or may not be aware that there's been a call for a separate group, or had been a call for a separate group to focus on diversity issues in the AAMC for at least 30 years now, since the inception of, I think GSA is about 30 years old. And there's been sort of on and off conversation about whether that, particularly with the focus on diversity becoming much broader than just medical students, right? And so to have just a minority affairs section, which MAS within student affairs, was awkward and less than maximally or optimally effective. What a decision was made to, and based on approval from both the GSA, AAMC leadership, and the Minority Affairs section, to maintain a significant presence in the GSA was important. And so a committee was formed that took advantage of the existing expertise of MAS, Minority Affairs section reps, and then expanding. With that as a core student-focused responsibility within GSA, the need to focus particularly on students became less the issue as the new group was being formed. And so, right, and so it's not, there is a challenge in connecting the dots now, and so there is representation on the board from GSA and CODA, GSA on the GDI steering committee, and vice versa. Right? But there are some sorry, there's a long one, but I think that history was very, is really noteworthy, and so this really is the GDI continues to evolve. It's not quite where it will be, but certainly the priority issues that relate to diversity have never been more important to focus on. So each year, GDI at the annual meeting is responsible for some core sessions, and in part that help to speak to the evolution of the issues and what folk are doing, and the opportunity to share some best practices and so on. So back to the one of the sessions, this was the session on faculty-focused diversity initiatives. One of the presenters, Dr. Quivera from Penn, gave an update on a survey of how U.S. medical schools are addressing faculty recruitment and development. And so the rationale being based on some of the current data at AAMC, and again, these data are available to you all as well, directly online or through the latest publication, Diversity in Medical Education, Facts and Figures 2012. Many of you have that. I think the hard copy may still be free for a short period of time, but certainly the online version is available. This, let me just highlight a couple of things from that graph. It is clear that you're not going to see it on the way anyway. It is clear that there's been a relatively flat line to any increase in diversity amongst faculty in U.S. medical schools by ethnicity, race and ethnicity. Okay? And then when you drill down to look at variations by or differences based on rank, the disparity becomes even more obvious. There's only one racial ethnic group, that one in the middle, for which there is less of a spread of rank amongst faculty between assistant professors, associates, and full professors. Right? However, when you look at gender within that, and I don't have that slide for you today, there are significant differences. So the relatively uniform spread by rank for white faculty is dependent largely on the outcomes, the successes of male faculty in that group. Okay, so it's not that all is still fine, even within that category. So that's just and I share this because I just don't want us to think that the focus on diversity is just about race and ethnicity. There's certainly other issues, or just about the numbers. Okay? And so in any event, the conceptual model that Quivera used in assessing characteristics of approaches to faculty recruitment and development across U.S. medical schools based on this, which comes out of some earlier literature, and these are very quickly jumping to his findings. Okay? Only about 30 schools of those who responded, it was about a 68% response rate, in the United States had actual formal diversity-focused faculty recruitment and development programs. Most are in the Northeast, and most were in elite schools, the top 20, and most were in schools with large numbers of faculty, 1,300 and greater faculty. Right? The support for the programs was largely institutional. About 50-60% of the funding to support those programs is internal, and certainly there's some external support as well, including from places like HRSA and occasionally the NIH. Most of the focus tends to be on mentoring, financial support, and climate. And incidentally, when you look at schools that had or didn't have diversity recruitment and development programs, those that did, in general, were more likely to have faculty mentoring programs and programs that focus on climate in general. Some of the less than enthusiastic news is that the evaluation of impact for those programs at the time the survey was done, this is in 2010, was largely focused on satisfaction. Right? So the relevancy here, well, we've been at this for some time. We are part of that 29%, and I'm happy to share with you, if you don't know, we're about a year, close to about 8 months into the formation of a diversity council, institution-wide diversity council. All right, so the sharing of focus on diversity is happening. The sharing of the responsibility for diversity, for faculty particularly, is happening. And the deliberations of that council to date will lead me to believe that within a relatively short period of time, our ability to have metrics across the board, across departments, that are more meaningful than just looking at satisfaction of faculty will be in place. Okay, so stay in tune. The next session I'll share with you very briefly was the GDI GME diversity session, and I will just focus on the session, just one of the several sessions that several panelists who presented on that. Some of you might recall last year what we brought home from this session was a template that had been developed by Northwestern, and we're at the point of tweaking and aiming to standardize that template for tracking the pool of diverse applicants, how decisions are made, and the ultimate outcome of the match by department. And so the goal is to have a standardized template that all departments will use, so that they'll be quite clear and with information to help address where the lesion might be as it relates to diversity of the residency programs by department. They make the case again based on population parity. This just gives you an idea if anybody had any questions about how Mount Sinai is doing relative to the nation. About 12% of the nation's residents self-identify themselves, or somebody helps with that identification, defined as being from groups underrepresented in medicine. The physician workforce is about 7% inclusive of groups underrepresented in medicine. That's about half of those numbers are not quite half of what the medical student body is, and even that is significantly lower than what is represented in the total population. The session of note, for me anyway, was one where there was a comparison of programs. One that was largely hospital-based, initiated and based by Mass General. The other that was more departmental-based, University of UCSF, and how they did over the course of the past 6 to 10 years comparatively. A few points to be made. Where you began, where the diversity initiative, particularly in this case at the GME, its launch makes the difference was the ability to have significant institutional impact, and sustaining the effort. The program elements were pretty much the same and not very different than many of the elements that exist in where there are initiatives to address diversity in GME here at Mount Sinai. I won't go into those in any detail. The fact that UCSF is largely a Department of Medicine initiated program that over time has become a program to help support institutional diversity, I think has put it in a different position. The impact of that program on the Department of Medicine has been tremendous. They've gone from 6% URM inclusion in the Department of Medicine back in 04-05 to about 15 to 18% URM inclusion a year or so ago. However, the impact on the institution as a whole has been more modest. And so they've not budged from about 7-8% total. And by the way, just back to the earlier the graph, about 12% on average of house staff across the nation are from URM groups. And then the question about sustainability is clear. It appears that once there's a plateauing, it takes some other new initiative to make a bump, but in the long run, that often is not good enough. And then, of course, if you look below the surface for both of the programs, the impact on specific departments is variable. All right, so no one shoe fits all. So the demonstrated programs of success in the Department of Medicine at UCSF, for example, are not necessarily the best model for even their Department of Orthopedic Surgery. Right? Lesson to be learned, well, this is sort of intuitive. We have come upon that realization here for some time, and our approach these days is really, just like for faculty diversity, is really to focus on individual departments, share best practices that may be generic, but help them to develop some more specific, specialty-specific initiatives that may begin to make the difference. Even more briefly, I'll share with you just a couple of highlights from the session on social determinants this year. Just as an FYI, there was a piece of literature that was referenced where just by the author's note, just by including a course on health disparities in the curriculum appeared to be responsible for attracting more diverse applicants to that School of Medicine. Okay. Interesting read. That's just an FYI. Okay. You should know that the University of Wisconsin is one of the few schools where there is an integrated School of Public Health and Medicine. So their actual name is the University of Wisconsin School of Medicine and Public Health. Okay? That positions them then to integrate curriculum for public health and medicine to address social determinants in a very unique way. All right? So their presentation was quite interesting. Some of the interesting products, they've taken about 170 students a year. They have developed this initiative called the Poverty Simulation, where they developed that initiative with one of their community organizations, the Missouri Community Advocacy Network. I won't go into much detail, but every single student goes through that simulation, right? And spend time with real live poor people in addition to a simulation, a couple of simulation exercises. In addition, to support their focus on advocacy, they have an applied approach where there are 5 advocacy tools shared with students as a part of that. They participate either in legislative testimonial, developing media that's very specific to advocacy. They learn the art and skill of persuasive conversation. the use of social media and become somewhat skilled in writing letters to the editor. They spend real time in their government legislative offices, participate in the process. Right? And so that's a real immersion experience that helps to support that social determinants curriculum. And of interest, the way in which they are aiming to measure success, they have really interesting baseline data based on what the content in the dean's letters, the graduation questionnaire, the graduation survey, and ultimately post-graduation surveys for residents. The University of New Mexico's approach that was shared was largely based on what they're doing with house staff. There's a mandatory rotation for family medicine residents that relate to public health and advocacy. Those are the competencies that are addressed, and they include some very core public health competencies that relate to disease surveillance, reporting, leadership, and advocacy. About 90% is experiential, only 10% didactic and case-based. And then that's followed up with a 2-year project that all the residents have to be immersed in. The evaluation includes a variety of things, including a 360 performance evaluation. And they intend to be positioned to do some comparative analysis based on the participants in the family medicine residency versus others. Okay. Let me take pause in the event that there might be some questions about what I've shared so far. And I apologize, it's a lot in a short period of time, but that's the way it was. Questions about any of that so far? Yes?
Do you have any idea what it means when the students from the University of Wisconsin spend time with real live poor people? Like,
What does that
what
mean?
did they actually do?
So that was a real live. Having experienced the simulation, then the next step was to try it out based on what they learned from the simulation, have a real life experience. Right? And we won't go into how they define people Bob, but I think that there is a lot to be said and in fact this was very much part of the model for the medical school, 30, 40 years ago, where students would spend time with patients across the street, just as part of their routine, right? And so so that immersion is really the point that they were trying to describe with folk of lower socioeconomic status as defined that way, right? So I probably could have articulated that a little bit differently if that's what you're picking up on, but that's the gist of what.
I'm just curious did they live with them?
So they were immersed in their experiences during the course of a month or so. And so they would, by mandate, spend a few hours every afternoon with those families over time. And not just experiencing their health needs or issues, but many of the other challenges that they were facing on a regular basis. Right? So that's sort of the gist of it. Okay. Probably there may not be another more impactful legal situation for U.S. schools of higher education, including medical schools, than the UT, the Fisher versus UT case that's sitting before the Supreme Court today. And so some of you who've been around for a while, and I saw that as I scanned the room, looks like some of you may have been either, at least in college, back during the days when the Baki case was under review. I was I'm comfortable admitting that I was a second-year student at Columbia College in those days. And David, you probably were still in elementary school, but that's okay. All right. And so the outcome of the Baki case of that deliberation didn't happen until '78. So that was a good news, bad news outcome situation, similar to what might happen with the Fisher case. Okay? The Baki case was the law of the land as it relates to the use of race as a consideration for decisions for admissions to higher education, right, 1978. The next significant challenge that the Supreme Court took up was in 2003, and I think most of us were around during that time, even David Muller, right, here at Mount Sinai, and we tuned in quite intimately. And so that also was a good news, somewhat bad news situation, although there were some institutions that were behaving as though we lost the case. We did not. And so there was clarity on what higher education institutions could do as part of admissions regarding the use of race. And most significantly is this point. Decisions that focus on race could happen, but that should be part of the characteristics that are under review, not the only case. And there needs to be narrow tailoring of how programs might be used to target diversity. So those were the significant outcomes of the 2003 Grutter versus Bollinger University of Michigan case. The outcomes, the relevance is not just for public schools like the University of Michigan or universities, but for private as well. Anybody who receives even a single dollar from the federal government have to apply by what comes out of that, and so on. The direct impact and relevance to us is clear. The implications will be on not just what we do, but what we have in writing, the policy, the practices related to that, all of the programs that look like, smell like, or are related and to support diversity, and how we evaluate the impact of our programs. Right. I won't go back to the history. I think some of you have a sense of where there's been some gain with diversity for medical school, particularly for students, and that the first significant bump was back in the 60s, 70s. There was no other significant bump in faculty diversity until since the 70s until the late 90s. So going from 2-3% URM to now about 7%. We've gone through that. Also of note, there have been several other non-Supreme Court cases of relevance to this. So the Hopwood case, University of Texas is a Hopwood state. And decisions from the Hopwood case even more narrowly define the terms by which Hopwood states could focus on diversity. Okay, and I'll come back to that in just a second. And then there are others going on, and some of you have followed what's going on in Arizona. Right? What's the context in which these decisions are being made? The Supreme Court is changing, and so the relative influence based on those changes on this decision could be pretty significant. Right? The case in brief is like this. So what Hopwood has guided the University of the schools in Texas to do is to use what they're calling a 10% rule. The top 10% of students in any and all high schools are admitted automatically to college, right? And either of their choice or banked on. But anyway, 10%. That's the 10% rule. Right? And what that has translated in general for Texas schools is that 90% of the students accepted to the universities across Texas are based on the product of the 10% rule. Okay? At the University of Texas, Austin, about almost 80% of the students who come in are a product of that, leaving about 19% or so who don't. The challenge by Fisher is for how decisions are made for that 19% of entering students to the University of Texas, Austin, not the whole. So the challenge is not against the 10% rule based on Hopwood, but on just how decisions are made on the basis of personal and academic attributes. All right, so that's really what it boils down to. Despite that, Okay, as deliberations occur, the focus on the judgment, the ultimate decision of that case, may be either narrow, just focusing on, how the university is considering that 19%, or more broadly, what they're doing in general to support diversity. So everything. And that's really where things get scary, right? And so what would be considered a win for schools, for people like me, and schools perhaps like Mount Sinai, would be that the Supreme Court totally approves the way in which the University of Texas Austin handled Fisher as an applicant, both as it relates to how the 10% rule impacts on diversity, and for that 19% who come in not based on the 10% rule. However, they might also make a decision that for which they just challenged how that 19% of students are coming in, which won't necessarily be a loss. However, they could make a decision that everything that Texas is doing needs to be reconsidered, in which case that ruling could overturn and have a reconsideration for the outcome of the University of Michigan decision, the Greta decision, which is currently the law of the land. All right, so I know that I apologize if that's somewhat confusing, but it is. But in any event, this is a deliberation for which a decision will probably be made at some point this spring, probably no later than June, July of 2013. The impact will be significant. What schools have been encouraged to do is to develop a management plan where they inventory any and everything that they are doing on all policies related to diversity for all programs, pipeline, outreach, admissions, student support, etc. How resources are used, including scholarship, and ensure that there is an alignment between policy, school mission, diversity mission, practices, and ultimately how these things are being evaluated. It is important that all schools that are focusing on diversity can be in a position to know when we've gotten there, right? And it's not just about numbers. And so the whole question of critical mass is just become so nebulous that could work, just using that as part of the argument, could work against what happens here. This is a diagram based on the guidance from one of the holistic review manuscripts that Coleman helped put together for the AAMC. It just gives you an idea of how activities and mission line up, and the ways in which the evidence, the evaluative evidence to support diversity has to be laid out or aligned or in alignment. Okay, so that's the process in which we need to be looking at and considering as we march along. But it's also important that we're not so far in front of the game, like what happened in several institutions back post-Grutter, where, and one university in particular, struck the term minority from every piece of literature that they had, right? And so that's an extreme interpretation of what people would say is the decision from the Grutter case, all right? So anyway, that's the quick update. I apologize if it's somewhat confusing, but it is. But I would say that Arthur Coleman, who gave this update, it was the best update on the Fisher case that I've heard, and the best and most succinct legal interpretation of what's in front of us that I think is out there. And if indeed there's a need for us to call on somebody like him to help guide us along the way, he certainly could be available to us. So let me stop there. There might be a question. I don't know if there's time for, I think we're about 3 minutes over, but certainly if there's time for one question, I'll entertain it. Otherwise, I'll stay around for 2-3 minutes before my next meeting, and that's it. So thank you for hearing those updates. I hope you're a little better informed than before you came in this afternoon. Thank you.